Hello and welcome to the Arc Woman podcast. This is an exploration of womankind. Here we discuss what it is to be a woman in the modern world while utilizing ancient and modern modalities in tandem to create a bounty of health for the body, mind and spirit. Hello Emma and welcome to the Arc Woman podcast. Thank you for being here.
It's lovely to be here.
Yay. Could you please tell us about how you got started being a pelvic floor therapist and what actually inspired you to go into that realm of study and work?
Yeah, for sure. So my name's Emma. I'm a physiotherapist. I work at the Pelvic Studio in Hobart, and I'm also the chair of the Australian Physiotherapist Association Women's Men's Pelvic Health Group in Tasmania.
I didn't know that.
Yeah.
Oh,
so just another little
wonderful
title. And it's a growing group in Tasmania, which is really cool as more and more people are doing the training. So I fell into working in pelvic health. I was working at the hospital at the time, and the opportunity came up to do some training in pelvic health. And so I got to go to Melbourne and did my postgraduate certificate at the University of Melbourne there.
Oh, wow.
So I started working after doing that. And then I moved into the private practice that I'm working at now, and I've got really lovely mentoring there from lots of the other physios, and now I get to mentor some of the other physios there as well, which is really great.
Wow, that's amazing that you fell into it. I've actually heard that story a few times from women falling into women's work.
Yeah, I had been working in palliative care, and it seems like a bit of a stretch, but I think it's moving from one taboo subject, death, to another taboo subject, our vaginas and women's health. So I think if you can talk to people about imminently dying, you can talk to them about their vaginas.
Yeah, life and death.
Yeah, exactly right.
All right, let's get into it because we've got quite a few questions.
Let's do it.
Okay, so can you explain what the pelvic floor is and why it's so important for women's health overall?
So the pelvic floor is a group of muscles that sit at the base of the pelvis. So they attach onto the pubic bone at the front and onto the tailbone at the back, and they form a bit of a bowl. And they have a number of functions. So one of their functions is to provide support to the pelvic organs. And when I'm talking about pelvic organs, I mean the bladder, the uterus, and the bowel. So they need to be able to be strong to support the weight of those organs. They also have 3 holes passing through them in women. So there's the urethra, where our wee comes out, the vagina, which leads up to the uterus, and at the back there's the anus, where our poo comes out. So we need to have good tone in our pelvic floor muscles so that we don't leak from the urethra and the anus, but we also need to be able to open around the urethra and the anus so that we can wee and poo normally.
Mm-hmm. Okay, so we need it to be dynamic.
Exactly
because what
right.
I've heard with pelvic floor is it needs to be strong, and now I'm hearing, it needs to be loose, and I'm like, what about it needs to be both? Because I feel like it needs to be strong enough to hold up everything, and then also hold up a baby. when you're pregnant.
Exactly right. And I guess one of the other functions of pelvic floor is sexual function as well. So we need to have the ability to allow penetration into the vagina without feeling discomfort there as well.
Okay, such a beautiful and simple explanation. Yeah, thank you for that. And it's nice to visualize that it is kind of like this hammock of muscle, and then we have these 3 gaps in it.
Yeah, as I was driving here, I thought I should have brought my model along.
That's okay. It was a beautiful visualization. So what are some signs of a healthy pelvic floor in women?
So let's start talking from the bladder side of things, what normal bladder function is. So you should feel a normal urge to go to the bladder, to use your bladder, to empty your bladder. So that means you're not going just in case a lot of the time, but you're also not waiting till you're busting and potentially even leaking on the way to the toilet. So you should be able to respond to the normal urge. You should be able to have a good steady stream when you're emptying your bladder, and you should feel like you've completely emptied when you do finish at the toilet. So you shouldn't have to go back 10 or 15 minutes later and do another wee, or you shouldn't be leaking straight after you're doing a wee. We also, another sign of a healthy pelvic floor when it comes to your bladder is that you shouldn't be leaking either on the way to the toilet or with stress. So when we say stress, I don't mean like, I'm feeling so stressed. I mean stress, pressure down onto the bladder. So things like coughing or laughing, running, jumping.
That old adage of like a woman who's given birth and like, I have to cross my legs when I sneeze.
Yeah, exactly right. And what I say about that is, yes, it's really common, but it's not normal. And just because you've had babies or just because you're getting older doesn't mean you should have to live with that. There's lots of things that can be done about it.
Yeah.
So those are kind of some of the bladder signs. If we're sort of thinking anatomically moving backwards, you should be able to have pain-free sex.
Yep.
And then if we think back to the bowels, as far as bowel movements we say anything from 3 times a day to 3 times a week is normal. So it's quite a spectrum of normal.
Okay.
But when you go, you should feel satisfied afterwards. So you should feel like you've completely emptied, and you shouldn't feel like you've got a strain to go.
Mm-hmm. Like a feather.
Good way of putting it.
Yeah, just I feel so free and light afterwards.
Yeah, exactly
you feel
right.
like it's a full, like empty kind of in a way.
Exactly right.
Yeah, because I have heard women say, oh, like in my clinic, I go 3 times a day, and I'm like, okay, but is it a full bowel movement 3 times a day? Or is it kind of like a quarter or a third bowel movement?
Yeah, that's right. So some people will feel satisfied 3 times a day after doing that, or some people will feel like they've done that first poo, but didn't quite get it all out and need to go back later.
Yeah, okay. And so conversely, what are some signs of kind of like so those were kind of signs of a maybe not so strong pelvic floor? So what are some signs of like maybe a hyperactive or overactive pelvic floor?
Yeah, you're right. So when we think about the pelvic floor, we want to make sure that it's strong enough to do all those functions, but also can relax enough. So if you had a pelvic floor that was had a difficulty relaxing, then you might have pain with sex or pain after sex. You might feel like you've got to strain a lot to empty your bowels, or feel constipated a lot. And when it comes to your bladder, you might have sort of a weak stream. You might find it hard to start the stream, or you might feel like you're not completely emptying your bladder.
Okay.
And then the other thing that we haven't touched on, I guess, is the idea of prolapse, which is where some of the pelvic organs, the bladder, uterus, or bowel, can descend into the vagina. Again, it's quite common, especially after childbirth. And signs of that would be feeling a dragging or a pulling or a heavy sensation around the vagina.
Mm-hmm. And so prolapse is mainly in the vagina. We don't see can you see anal prolapse and bladder prolapse as well? Or
yeah, so if we think about the walls of the vagina, so the vagina is like a bit of a tube. The front wall is where the bladder sits. So you can have a bladder prolapse into the vagina. The top wall, like the end of the tube, is where the uterus and cervix sits. So you can have the uterus come down into the vagina. Mm-hmm. And then the back wall is where the bowel sits. So the bowel can come into the vagina. And then there's a different type of prolapse called a rectal prolapse, where the end part of the rectum prolapses out of the rectum rather than into the vagina.
Okay, so there's 4 types of prolapse, and 3 of them will prolapse into the vaginal wall.
Yeah, because that's where the space is.
Wow. Okay, so you need to have a daily kind of communication with your vagina to kind of make sure that that's not happening in a way, and just know what your normal is.
Yeah, knowing what your normal is right. And lots of people will have anatomical prolapse, so they will have some movement of their bladder, uterus, or bowel without having symptoms of prolapse. Mm-hmm. And certainly some amount of movement is normal, like in any of our joints and muscles, you need to have some movement. Mm-hmm. But if it's impairing your bladder function or your bowel function or your sexual function, or stopping how you do things, if you feel those symptoms going for a run or going out in the garden, doing heavy lifting, then that's when you would seek help.
Yeah, okay. And so it's just those things to look out for, like everything you basically said. If something changes, don't ignore it. Please just go and see a pelvic floor therapist pretty much straight away.
Yeah, exactly right. Sometimes we even get people coming to see us regarding prolapse who might have had it identified by their GP doing a pap smear, and they didn't realise that they had a prolapse. And then when the GP said, on your pap smear it looked like you had a bit of a prolapse, then they start to think, that heaviness that I feel when I'm moving around the garden, that's not normal. Or not being able to empty my bladder properly, or feeling like it takes a while to empty my bladder, it's become normal to me, but actually it's not normal.
It's like boiling frog. The analogy
exactly
of the frog in simmering water to boiling and then hopping into boiling. I just feel like these changes are so incremental, and women just don't change or see that it's changed until it's gotten so bad. I've actually had a friend reach out to me kind of in the past couple of years actually and said, I see my uterus at the absolute opening of my vagina. What's going on? Yeah. I was like, that's a prolapse.
Yeah.
And she was like, what? I'm 24. How is this supposed to be happening? I'm like, well, what were all the incremental changes? And she was like, actually, yeah, I did see change. And we talked about why she didn't actually notice these things, but I think mainly it's shame, right? Like women don't actually want to talk about this part of their body.
And particularly because prolapse is quite common after the childbearing years, women are giving their priority, their time to their kids or their work, and not putting that time for themselves. So often we will see women when their kids have hit maybe primary school or high school and they think, oh, finally I can do something about me now. And it's never too late. You know, even though we always say prevention is better than a cure or early intervention is best, it's never too late. I see women in their 80s and 90s who still have goals to meet and can still make changes.
Oh, that's so beautiful and hopeful. I love that, because I think there is an idea that women, oh, you know, once you pass menopause, you just everything goes and that's just what it is. But it's nice to see that there is like hope.
Yeah, never too late.
So why is it equally important to be able to relax the pelvic floor as it is to strengthen it as well?
It's important to have a strong and mobile pelvic floor so that we can have our normal bladder, bowel function and normal sexual function. So if you think about let's talk about the urethra, where our wee comes out, being like a pipe, and the pelvic floor muscles kind of wrap around that. If we're always squeezing around the urethra, it's actually really hard to empty our bladder properly because there's extra pressure. So we need to be able to relax around the urethra so that we can get a good flow of wee. And the same thing happens with the bowels. So particularly with the bowels, when our pelvic floor muscles become a bit tight, the bowel gets kind of a kink at the end of it because the pelvic floor muscles sort of pull it in one direction. So particularly if we've got a bit of a firmer poo, we're going to have to put a lot of pressure down to get it past that kink. And putting pressure down onto our pelvic floor can lead to things like prolapse and hemorrhoids.
Yeah.
So if we can relax our pelvic floor, particularly when we're pooing, then there's less of a corner to get round. So we have to put less pressure onto the pelvic floor.
Right.
And, you know, for something that we're doing up to 3 times a day, then that's pretty important.
Yeah.
And then the other big thing is around sexual function as well. So if our pelvic floor muscles have difficulty relaxing, then people often say it feels like there's a block when I'm trying to have penetrative sex, like it just hits something. And that can sometimes be the pelvic floor muscles sort of tensing. And there's lots of reasons why that can happen. I'm sure we'll go into that, or I can talk about it now.
Yeah, I mean, just before you go down that thought stream, can a tight pelvic floor increase a woman's likelihood of UTIs as well? Because I'm thinking if we have a tightness around the urinary tract, then does that mean it's harder for women to urinate, which means they're more likely to get infections because we're not passing urine frequently?
Yeah, that's right. So one of the things that we can test in our clinic is it's called post-void residual, or after weeing how much is left in the bladder. So we can do it with an ultrasound where we check the bladder volume on an ultrasound initially, then we ask you to go and wee, and then you come back and we pop the ultrasound on again and we can see if there's any wee left in there. And you're right, if you're not emptying your bladder completely, then you increase your risk of getting a UTI, but it also can mean you have to go back to the toilet more frequently. Because say you start with a full bladder, might be 400 mils for you, and then you go to the toilet and you only empty 200 mils, you're only going to have to fill it up another 200 mils before you feel the need to go again. So yeah, a big part of what we do is teaching women to completely empty their bladder to avoid having to go back so frequently and to avoid the risk of UTIs.
Yeah, okay. Thank you. And then do you mind continuing on where you were going before and talking more about like sexual health and down that realm?
Yeah. So there are lots of reasons why women can have pelvic floors that have difficulty relaxing. One of them that we know is a history of sexual abuse or sexual trauma or any sort of adverse childhood experience. So that can be sexual abuse, emotional abuse, physical trauma, even things like parents divorcing can lead to tension in the pelvic floor. I'm not saying this has happened to everyone who's had those experiences, but there is a correlation between those experiences and pelvic pain and difficulty relaxing pelvic floor. So what we find is that a lot of people tend to hold tension in their pelvic floor. So some people might hold tension in their neck and their jaws and their shoulders, and you say to them, oh, can you just relax your shoulders? And they go, oh, I didn't realize that I was holding tension there. And that's often what we find in the clinic, that people come in with symptoms such as pain with sex. We do an examination and we find out that they're holding tension in their pelvic floor, and then they start to realize throughout the day, oh yeah, when I'm feeling more stressed or more anxious, I hold it in my pelvic floor. So having that information can be really powerful for women because they can start to take control over something that's been happening without their control before.
And in my research, which I found was really interesting, is that the pelvic floor is skeletal muscle. It's not smooth muscle, which means we have control over it, which blew me away because I thought it was smooth muscle and we didn't have control over it. And then I found out that, like women can hold tension in this area, especially if that makes sense if you've experienced sexual trauma or even traumatic life events, and that's just automatically where you're going to hold that space and to tighten up.
Yeah,
which
exactly
makes
right.
kind of total sense to me in a way, because if you're, when you're a cycling woman, if you're experiencing stress, cortisol is going to stop GnRH from releasing, which means you stop cycling altogether and your body won't ovulate. And it kind of makes the same thing. Like if you experience like a traumatic life event and your pelvis tightens up, that's basically your body trying to protect you basically from something happening again.
Exactly right. So sometimes we see it after childbirth as well, particularly if a woman's had a more traumatic childbirth. Maybe there's stitches there, maybe there's a little bit of muscle or ligament damage. The body will go into protect mode. The muscles will become kind of more rigid to try and hold everything together, which is a short-term solution, but if it persists long-term, can create issues.
Yeah, well, maybe let's go down into that direction and start talking about like pregnancy and birth and pelvic health, because I think that's most of what everyone wanted to find out about. So how do different pelvic floors, tight versus weak, impact our birth outcomes, and whether a woman is going to have like an easy time or a hard time, or I guess they both have positives and negatives as well?
Yeah, for sure. So there's really great evidence from studies of thousands and thousands of women that show that doing pelvic floor exercise that's supervised and individualized to you during your pregnancy is great during pregnancy because it reduces your risk of incontinence during and after pregnancy, but it also has an impact on birth outcomes. So we know that having done pelvic floor exercises during your pregnancy reduces the pushing phase of labour. Wow. So we know that pushing phase of over sort of an hour and a half or 2 hours can have some negative outcomes. And we also know that it can reduce the risk of the severe perineal tears. So when we're talking about the perineum, that's the area between the vagina and the anus, and it's the area that's most at risk of tearing during a vaginal birth. There are 4 grades of tear. The 3rd and 4th grade of tear into the anus, which, isn't nice for anyone and can lead down the track to things like fecal incontinence. So we know that doing pelvic floor exercise during your pregnancy can reduce the risk of those severe tears. But it's not just about strengthening the pelvic floor. So we want to have a strong pelvic floor during pregnancy to support the growing weight of the baby and all the other things that come with that, the extra blood supply, the extra fluid, the extra breast tissue.
The huge placenta.
Yeah, exactly right. But we also need to have a pelvic floor that can relax. So during childbirth, the pelvic floor muscles stretch up to 2.5 times their normal resting length, which no other muscle in the body can do. Could you imagine if your bicep or your quads did that? So that's, a physiological thing that happens during childbirth. Yeah, incredible that it can happen. But if you are someone who has difficulty relaxing your pelvic floor, then that might be more difficult during childbirth.
And that kind of plays into that statistic we were talking about before, where they had 1 out of 3 women, when they asked them to bear down, they actually tightened their pelvic floor.
Yeah, exactly right. So that's something that we're looking a lot more closely at in clinic just over the last couple of years. When people come to see us for a pregnancy assessment, as long as it's usually after their 20-week scan, so we know that there's no issues with the placenta or their cervix that would sort of contraindicate bearing down. And we can check and take some measurements of what's happening when we do a simulated push. So not like a full-on pushing out a baby push, but just what happens when you ask a woman to bear down like she's pushing out a baby. And studies have shown that 1 in 3 women, when you ask them to do that, will actually contract their pelvic floor, which is counterintuitive because it's reducing the space that there is for the baby to come out. So what we can do in our clinic is an ultrasound assessment, a transperineal ultrasound. So that means putting the ultrasound probe on the perineum, that space between the vagina and the anus, and we can ask you to bear down and see what's happening and take some measurements and work out what cues are best for an individual woman.
Right.
And I can talk about my personal experience here with, I've got 2 kids. My first kid was before I knew about this research. And I felt like I didn't, when it came to pushing him out, didn't know how to push, and I ended up having forceps. Then I fell pregnant with my second baby. This research came out. So one of the other physios did a transperineal ultrasound on me and found that the cue push like you're pushing out a poo just didn't work for me. So we had to work out what cues were going to work for me, and then had a really straightforward birth with him.
Do you mind if I ask you what the cues were?
Yeah, so the one for me was to stick my thumb in my mouth and pretend I was blowing it up like a balloon, like.
Oh, yeah, okay. That does impact your pelvic floor.
Yeah, so you can feel that sends pressure down to the pelvic floor. So it's to do with the glottis, which is kind of, if we think about our core, the tummy muscles are the front of the core, but they're only one part of the core. The pelvic floor muscles at the bottom. We have our back muscles, multifidus, at the back, and then the glottis near our throat is the top part of the core. So we need to be able to close the glottis to send that pressure.
Okay, so
downwards.
Loose jaw, loose vagina kind of thing. That's what I've heard midwives say over and
loose
over
lips,
again.
loose lips.
Lips. Okay, there we go. Okay, because they had another question that was kind of related to that when a woman does Kegels, she feels pain in her jaw and tension in her jaw. Is that because it's connected through the abdominal core system to our pelvic floor?
Yeah, it's something that we often find when people turn their pelvic floor on, then they can get that tension around their jaw. So often what I'll do before I start teaching someone how to turn their pelvic floor on is just do kind of a full body scan to make sure the full body is relaxed. So often we see jaw or hands or inner thighs might be clenching, and it's really hard to relax your pelvic floor muscle if the other parts of your body are feeling tense.
That's so fascinating. Thank you. I'm thinking about all these other questions and I'm like, no, rein it in. So do you mind if I ask you how pelvic floor changes throughout pregnancy and then postpartum, and like what women can do, like what exercises they can do, and how maybe they can connect with their pelvic floor to make sure that everything is okay through that process?
Yeah, so there are amazing changes that happen around our pelvic floor over the course of pregnancy. And important to note at this point as well that these changes are happening regardless of whether you're planning a vaginal birth or planning a cesarean. Like, your body doesn't know that you're potentially thinking about a cesarean. And I think a lot of people think that having a cesarean is kind of letting you off lightly from a pelvic floor perspective, but you still need to think about it. Some of the hormones that we have during pregnancy influence a lot of the connective tissue, so the ligaments and tendons around the pelvic floor, and help them to soften.
Estrogen pulls up on the ligaments, right?
Yes, but it can also keep things soft and then relax and keeps things soft as well. So this is a whole nother rabbit hole that we won't go down, but people talk about pelvic instability during pregnancy, which is a term that I don't really like because our pelvises are inherently stable joints. But there is a hormone called relaxin that does soften a lot of the ligaments, particularly around the pelvis, because we do need to have a little bit more movement in our pelvis for a baby to come out. So relaxin does keep things a little bit soft around the pelvis. There's also a lot more blood flow going to the pelvis during pregnancy, which is a good thing mostly, but some people will feel it as like a swelling or a pressure or a heaviness. And there is potential for kind of varicose veins of the pelvis to become, or of the vulva to become a problem during pregnancy, because all the blood vessels are able to dilate a little bit more easily during pregnancy, which can lead to those varicose veins. The other thing that we track across the course of a pregnancy is what we call the genital hiatus. So it's kind of the opening of the vagina from the outside, and that we see increases across the course of a pregnancy, getting ready for a baby's head to pass through.
Wow. So it doesn't matter if you get a C-section or not, these changes have already made place, and that your pelvic floor is already increased by 2.5 times. So it doesn't matter what type of birth you have, you still probably have to do some postnatal care.
Yep, exactly right. It might be worth touching on something that we often do with women in the third trimester from about 34 to 36 weeks onwards, called perineal massage. I don't know if that was one of the questions.
I was thinking about that. I was like, I need to ask you a question about that. Yeah.
Yeah, so really good evidence for perineal massage in the last 4 to 6 weeks of pregnancy, reducing the pushing phase of labour. So if we can shorten that pushing phase, that's always a good thing.
Yeah.
And reducing the risk of severe perineal tears. And a lot of women who do perineal massage report a more positive experience of labour. And we don't know exactly why that is, but it's potentially because they have a bit more familiarity with some of the sensations and some of the anatomy around their pelvis. So, we teach women, massage is probably a light term for it. It's quite a strong stretch that we can give to the pelvic floor muscles. I like to think of it as a bit of a dress rehearsal for birth. So I encourage women to, put on their candles and their nice music and get comfortable before they do the perineal massage, so that they're kind of in that birth headspace, and then they can get used to trying to relax their pelvic floor muscles with that stretch or that massage or that pressure.
And what is the stretch and massage? Do you feel comfortable sharing that?
Yeah, so you can do it by yourself, or it's probably easier for most people to get a partner to do it. Again, I wish I had my pelvis model here. But we use 1 or 2 fingers inside the vagina to stretch the pelvic floor muscles. And the idea is that the woman is learning to relax, like to go with that stretch, rather than the natural instinct for most people is to fight against it. Yeah.
Okay, so we're kind of maybe in a malasana pose, or like if that's comfortable for someone, kind of like a deep squat, maybe?
Tend to do like more reclined, or even in the bathtub, like somewhere where people are feeling relaxed. I think in a squat it would be, you could try it, but it'd be like tricky to,
especially with a big baby bump.
Yeah, exactly right.
Okay, so you're kind of, because I was imagining perineal massage was just massaging that space between the anal opening and your vaginal opening, and it's not. You're actually kind of
you're inside
and you're pulling down, kind of in a way, very gently.
Yeah.
Wow. Okay.
Yeah. I think they need to rename it.
Yeah. Well, yeah, it is perineal, kind of like lower vaginal
but it's
opening.
Like inner perineal, not outer perineal
massage. Yeah. Okay, great. And that's for 4 weeks before you give birth.
Yeah.
Yeah, wow. And so it's just kind of, instead of you tightening up and then increasing your risk of stretching and kind of tearing that muscle.
Yeah, or like blocking the baby's head from coming down as well. Because if you're tensing that muscle, it's not allowing the baby's head to move.
Right. So kind of training. Oh, it's almost like women like hold on to ice before they give birth so they can get really comfortable with being uncomfortable. But that's a different way that you can kind of go, this is one of the sensations of birth. Like this is how you can stretch out and feel very comfortable with this sensation.
Yeah.
Yeah.
Exactly right.
Okay, that's wonderful. And on the other side, like what happens if women don't have a very strong pelvic floor? Can that impact birth in a way?
So not having a very strong pelvic floor, or having a pelvic floor that kind of stretches too much or is too lax, can lead to issues like prolapse. Okay. So there are a couple of risk factors for prolapse when it comes to birth. Things like a long pushing phase, or the use of instruments like ventouse, but more so forceps. And the risk there is that you can get what's called a levator avulsion, where some of the muscle fibers of the pelvic floor muscles can come away from the bone. So it kind of increases the opening of the vagina and means that there's more space for the bladder, uterus, or bowel to move into. And it can increase the stretch on the ligaments that are supporting the bladder, uterus, and bowel. So they're not getting that nice strong support from above, which can mean that they can sink into the vagina.
Okay, right. So you need a balance. So what do women do after birth? So regardless of like if they have had like kind of a lax or overly strong pelvic floor, what is some general advice you offer to women? Because I see people on Instagram all the time, like these fitness influencers who are like 6 weeks postpartum going and doing high intensity interval training. And yeah, so your body might be fine, but I'm like, is that good for your pelvic health? I'm not so convinced.
Yeah, so the big things that we encourage women to do in the first few days and weeks after giving birth, and this is again regardless of a vaginal birth or a cesarean, are to rest. Yeah. So horizontal rest is so important in those early few days, and weeks, because if you have a lot of swelling around the pelvic floor, if you think about, swelling in your ankle because you'd hurt ligaments in your ankle, we're going to tell you to rest and elevate that joint. It's a bit harder to elevate your pelvis, but the closest you can get is lying down flat. Mm-hmm. So when you lie down flat, it helps with the swelling and allows those ligaments to not be constantly under the influence of gravity, so that they can have a bit of time to repair.
That's such a beautiful visualization to go, okay, you're stretched out your pelvic floor. That's natural. It's healthy to be able to do that because you've just given birth and you've had a baby. But now we need to allow that to come back into place, and you can do that by being horizontal and not allowing that gravity.
Yeah, exactly right. So horizontal rest is one of our big things after birth. And another one is avoiding constipation or managing what your bowels are doing, because you want to avoid straining, which again is putting lots of pressure down onto the pelvic floor. And if we think about some of the factors around birth that might predispose you to constipation, for instance, you might be on some pain relief medications, which can often be quite constipating. If you're breastfeeding and your milk's coming in, you might be getting a bit dehydrated, and that can cause constipation as well. Potentially you're like eating different foods than what you normally would because you're not you're not normally getting to cook for yourself, that sort of thing. So that can influence constipation. So we really encourage women to be really proactive with their bowels in those first few days and weeks to make sure that they're not putting unnecessary stress.
So chewing lots of gum, lots of magnesium citrate, I guess, to kind of like loosen up that sphincter and maybe allow that bowel process to be a lot easier.
Yeah, making sure they're keeping on top of fluids as well, making sure they're getting a good amount of fibre in, and thinking about their position on the toilet as well. So that's something that we haven't touched on.
Can we talk about, like squatty potties and things like that? Yeah, because I hear a lot of women being like, I don't know, like I need to squat on the toilet in order to go. Is that normal? Is that not normal? Should I be able to just sit on the toilet? Yeah. And I've just spent 3 months in Southeast Asia, and I'm like, I don't think any of these people have any constipation issues because of how they sit on the toilet. They have toilets in the ground.
We were designed to squat to poo, basically. And however many 100 years ago, toilets were invented, and now we sit. And when we sit with our hips at a right angle, like you would on a sort of normal toilet, we talked about that angle of the bowel and potentially being impacted by the pelvic floor. Well, that's impacted by the pelvis position as well. So when we're sitting sort of up straight like we think we should on the toilet, the bowel has that kind of kink to get the poo out.
So we need more force applied to be able to get it through that kink, and that means we're not actually having a full excavation.
Exactly right.
Right.
So if we sit with our knees higher than our hips and leaning forwards a bit, so you think about the angle at your hips being more acute, then it straightens out the end part of the bowel and means that you don't have to push as hard to evacuate your bowel.
So kind of having like a little stool at the base of your toilet.
Yeah, exactly right.
And kind of allowing your knees to be higher than your hips.
Yeah. Some people will find that they come up onto their toes to get their knees higher than their hips, but that can kind of activate a lot of the muscles around the thighs to keep you in that position.
Which will tighten your pelvic floor.
Yeah. So I encourage flat feet on a stool rather than up on your toes. And then the other thing is, we use the word open your bowel because that's what's got to happen around the anus to empty your bowel. We don't sort of push it out or whatever. So you want to think about that relaxation and sense of opening around the bowel, and you can use your breath to help with that.
Can we talk a little bit about breath as well? Because again, in my research, I was so surprised how many times I heard like pelvic physios talk about breath and deep belly breaths. And also can we, alongside that, talk about like clothes that press into the belly and women who suck in their belly, and like how all of these things negatively impact the pelvic floor?
Yeah, where do we start with that?
Yeah. I feel like they're kind of all intertwined in their own way. But yeah, like shallow breaths. So I know a lot of women, like I think you can't really talk about pelvic floor without talking about patriarchy and like how it is stressful just for women. I find women have very shallow breaths all the time, and how can that impact our pelvic floor?
Yeah, so a lot of what we teach people in our clinic is how to take a deep breath, because when we breathe shallowly, we don't get the chance to allow the pelvic floor to kind of naturally move a little bit with the breath. But when you take a deep belly breath, it's much easier for the pelvic floor to kind of open and expand. the other thing when it comes to breath is kind of coordinating your pelvic floor contractions with your breath. So some people, if we're trying to teach a long endurance hold, which is one component of pelvic floor muscle training, lots of people will hold their pelvic floor but also hold their breath at the same time. And it's hard for them to kind of disconnect the two things. So a lot of what we do is teaching people to be able to hold their pelvic floor for a long endurance contraction, but maintain a normal breath while they're doing that. And it's a real like coordination, patting your head, rubbing your tummy kind of thing to separate those two things.
Yeah, wow. And so what would you say, like, so when we breathe in, have a deep belly breath, our diaphragm is moving outwards and slightly down. And so that's when our pelvic floor should be relaxing.
Yeah.
And then when we're breathing out and our diaphragm is moving up, that's when our pelvic floor technically should be having a little bit more tone.
Yeah, you kind of want to coordinate it a bit. So I often will teach people to, if they're just starting out with pelvic floor exercises, start with a few full deep belly breaths first and think about sending that breath down into your pelvis. And at the end of a breath out is when you think about that contraction and then let it go and take a breath in between.
Kind of like a wave in a way, like allowing it to come out and then come back in. And then also being able to control that so you can breathe in and out and hold it at an out or at an in a way.
Exactly right.
Okay, interesting. So can we come back to that question? Sorry, I asked you 3 in 1. I got a bit excited. But women wear really tight clothing and then also suck in their bellies and have this whole idea that I think women just, have been told that their lower belly they should be ashamed of that and they should suck it in and we should all have like washboard abs. So like how does this negatively impact women's pelvic health?
Yeah, so that can change the way the pressure is kind of distributed around that core unit. And sometimes we do actually encourage compressive garments for some people, but like medical grade compression, not just tight skinny jeans, to help them manage the pressure. Like if they've got a lot of pressure going outwards into their tummy, potentially they might have a diastasis of the rectus abdominis muscle or an abdominal separation, which is a whole other kettle of fish. But if they have difficulty managing the outward pressure, then sometimes a bit of gentle compression can help with that part of the core. But if you're constantly sucking your tummy in, often the deep core muscles at the front and the pelvic floor muscles kind of work together. So often if you're sucking in at the tummy, you're sort of sucking up as well from the pelvic floor and holding tension there. And the pelvic floor muscles are a postural muscle, so they do need to have kind of a low grade constant tension so that we're not leaking, but they don't need to be on all the time. So if they're on all the time, it can affect bladder bowel function, cause pain, those sorts of things.
Okay. Yeah, so don't hold your tummy in, don't wear super tight clothing, basically. Yeah, but can we talk about compression though? Like, would you recommend compression for women who are postnatal? Is that something helpful for women who've just given birth?
Yeah, often it is. And if we go back to the ankle ligament analogy, having a swollen ankle, we'd go rest, ice, compression, elevation. So we've talked about rest, we've talked about, you can put ice on your perineum as well, and there are all sorts of products out there now that help you manage ice on the perineum rather than just straight out ice cubes. And so compression, again, compared to being able to wrap your ankle with a compressive bandage, it's a bit hard around the perineum, but there are garments that can help with providing that pressure sort of upwards onto the perineum to help with recovery. So the most studied brand is called SRC. So they make shorts and leggings and tights to help give that compression.
And that's going to support the pelvic floor when we are standing, and it kind of like counteracts gravity a little bit, so we can hold that up a little bit more.
Exactly right. And SRC have also in the last couple of years brought out, I think they call it the Restore garment. So it's actually for people who have prolapse, and it's like a support there. And it's more research coming out the last few years about supportive underwear for prolapse that can be helpful in that regard as well. So it's not a commonplace treatment yet, but it's nice to have the option there for some people.
I did remember when you were talking about that, I'm like, oh my gosh, I remember one of my like old boyfriend's mum was always joking about how she always had to wear tight skinny jeans to hold her prolapse in. Yeah, and so I'm like, oh wow, she was like self-medicating something that now is well studied and we have proper products for it.
Yeah.
But she kind of intuitively knew that like gravity is going to be making my prolapse worse, so I need to use something else to hold it in.
Yes, but there's other options than skinny jeans now.
Oh, yeah.
Thankfully.
Skinny jeans is not the option. But yeah, I remember it was summer and I was like, why are you wearing skinny jeans all the time? And she was like, babe, I've got a prolapse. I've had 3 kids.
Yeah.
And so it was really sad actually, because I remember thinking like, oh, should we be normalizing that? I don't think we should be normalizing that. Yeah.
I think our generation is quite lucky that we have this knowledge now that those things aren't normal. And we do sometimes see people come in who are pregnant or postnatal and see us for their pelvic health. And then a couple of weeks or months later, their mum comes in because their mum didn't get the opportunity to have this experience or, learn about their bodies in this way when they were having kids.
Is there a genetic component to prolapse as well?
Yeah, for sure. It's one of the big risk factors, and it's to do with the makeup of our collagen. So some people's connective tissue or collagen is naturally more stretchy than others.
So more hypermobile?
Yeah.
Okay. So that kind of goes into like the POTS hypermobile kind of conversation and how that might be genetic, and like if you have a high risk of hypermobility, your pelvic floor might have a higher risk of prolapse.
Yeah, or other pelvic floor dysfunction, because often what we find with people who are hypermobile, which means that their ligaments and connective tissue are a bit more stretchy, they will compensate for that extra mobility by tightening their muscles. So it can kind of go both ways.
Right.
Yeah.
Okay. So if someone is suspecting a prolapse or they're feeling that dragging, what's something that they can do?
So the things that we would look at as a physio is to work out what is prolapsing. Firstly, is it the bladder, the uterus, or the bowel coming into the vagina? And base our recommendations around what's prolapsing and also the grade of the prolapse, so how severe it is. Some general recommendations that we give are around helping avoid pressure onto the prolapse or onto the pelvic floor. So things like avoiding constipation, which I keep coming back to, but it's so important. Avoiding lots of heavy lifting if you're noticing that when you put that pressure or when you lift something heavy and that puts pressure down onto the pelvic floor, you're getting those symptoms.
So interesting, because I hear all the time that you should lift up heavy things to strengthen your pelvic floor. So you're saying that it can actually worsen prolapse
if you're not doing it with good technique.
Okay, right.
Yeah.
Okay.
And if you're finding that like long periods of standing sometimes worsen your symptoms, then we'd recommend getting that all important horizontal rest in as well. Then we also think about the role of the pelvic floor muscles, because they are kind of sitting at the base of the pelvis and potentially providing support for those pelvic organs. So having pelvic floor muscles that are strong enough and functional enough in terms of being able to turn on and off to support the pelvic organs is really important. So pelvic floor muscle training is kind of one of our first steps in managing prolapse, but for some people it doesn't quite cut it. If they have had more damage to the ligaments that are supporting the organs, then having a strong pelvic floor from below is not going to fully counteract that. So we can think about things like pessaries. So a support pessary is a silicone device that is fit by a physio or a GP or a gynae into the vagina. There's all sorts of shapes and sizes that it comes in, but the common ones are either a ring, like a kind of a donut shape, or a cube shape, and they provide support to the pelvic organs. Historically, like way thousands of years ago, they would actually use pomegranates as the first pessaries.
Like the fruit?
Yeah, so they'd cut it in half, use it because it's the right kind of shape, and there was sort of antioxidant properties in pomegranates.
And so what do? We're placing it at kind of the base of the cervix in a way?
Yeah.
Okay.
Yeah, so it sort of props up and gives support to the pelvic organs.
Wow.
And 20 years ago, a pessary was mostly used for women who were perhaps considered not a good surgical candidate, because of course a surgical repair of a prolapse is an option. But then we went through the issues with transvaginal mesh, where lots of women who'd had prolapse surgery were having issues with the mesh migrating or pain related to the mesh. So started looking at what might be some other options to support these women without going down the surgical path. So there's been a lot more research the last 5 or 10 years into pessaries. And we're now starting to think that rather than just being like a kind of Band-Aid solution where you pop a pessary in and that's what you've got to have for the rest of your life, there might be a role for a pessary as a sort of a stepping stone to allow the ligaments to re-knit. So if we can hold the pelvic organs in the correct place using a pessary for enough time, then the ligaments holding up the pelvic organs will have a chance to re-strengthen. And often what we see is that a woman might start using a pessary all the time, for perhaps the first 6 to 12 months, and then over time she can start weaning off it. So she's perhaps only wearing it if she's going for a run or going to the gym or going out in the garden, doing something that is going to put pressure down onto her pelvic floor. And then there is, I think the most recent study was like 1 in 6 women, and this was in older women, kind of, I think the average age was 60 or 70, will be able to wean off the pessary completely.
Wow.
So there's some really promising evidence coming out as far as pessaries go.
Because I think that's one of the fears that I think especially older women have because of all the, I think there's been fear mongering around the mesh, but also kind of grounded. I mean, I've heard some pretty horrific stories of pain and pelvic pain associated with that. So it's nice to know that there's kind of an in-between that women can choose that's going to allow their body to reconnect those and re-knit those fibers and the ligaments.
Sure. And often we see people using a pessary prior to surgery, like perhaps they know that they're eventually going to have surgery, but they want to put it off for as long as they can, so they use a pessary in the meantime. And we also find that having a pessary in can often mean that the pelvic floor muscles can actually do their job properly, because if you've got a prolapse where the organs are kind of sitting onto the pelvic floor muscles, it's really hard for them, like they're working under this extra kind of weight. So if we can lift the organs back up, it allows the pelvic floor muscles to do their job properly.
Right. Okay, so interesting. And so like women of all ages can use pessaries. So postpartum, and then even I've had a lot of questions about women who are like, I've never given birth. Why am I experiencing prolapse symptoms? Does our pelvic floor over time, if it hasn't been supported properly, start to disintegrate?
So disintegrate's probably the wrong
probably
word.
Probably not the right word, sorry. But like all the other words, like I don't want to use dysfunction as well. Like what would be the correct term that you would use?
We would use dysfunction.
Oh,
actually,
okay.
Probably. Yeah,
all right.
we'd say pelvic floor dysfunction, which is also not that nice a word, is it?
No.
So the biggest risk factors for prolapse are your genetics, which we can't change, and your first vaginal birth. So if you had a big baby, so over 4 kilos, forceps or prolonged pushing phase, those are kind of the main risk factors. Subsequent vaginal births do increase the risk a little bit, but not as much as that first vaginal birth. But other risk factors include things like chronic constipation, where you're often having to strain and putting pressure down on the pelvic floor that way. Chronic cough, which again, if you think about when you're coughing, there's lots of pressure going down onto your pelvic floor, or lots of kind of manual labor with poor form where you're not managing the pressure around your tummy well, so there's lots of pressure going onto the pelvic floor.
Could other things like PCOS and endometriosis impact this as well? Because I know with both of those conditions, there's excess inflammation in the pelvic region. Could that allow more pressure in that area and increase the risk of prolapse and pelvic floor dysfunction later in life?
That's an interesting question, and I don't know that it's been studied. What we tend to find more, particularly in people with endometriosis, is that pelvic floor muscles are really tight and have difficulty relaxing, and that actually does reduce your risk of prolapse if things are holding on really tight. Hypermobility is one as well, though. I saw someone in the clinic during the week who, I think she's 36 or so and hasn't had kids, but is quite hypermobile and does have some elements of prolapse, and she's had constipation as well. So sort of 2 risk factors there.
Okay, really interesting. I think that's kind of a risk factor with women with PCOS because they have such high amounts of cortisol, and that means that they have a harder time passing their bowels. And then because if they have cysts and stuff as well, if they have huge amounts of cysts, they can have more weight in that area. But that's interesting about endometriosis, that you've seen the opposite problem, because I would assume from my clinic, because I see constipation as a constant issue with women with endometriosis and pain, obviously, that, of course, it's creating more tension there. So you have less of a risk of prolapse, but more of a risk of possibly like extended birth time and all these other things as well. Yeah, interesting. So can women with hemorrhoids address this issue through pelvic floor physiotherapy?
Yeah, for sure. So even though we call ourselves pelvic floor physiotherapists, where we do more than just the pelvic floor muscles, so we can address kind of overall pelvic health, which includes bladder health and bowel health. One of the risk factors for hemorrhoids is constipation. So we can do some basic, we call it stool manipulation, which just means looking at what the consistency of your stool is. So do you need to think about your fluid intake, your fiber intake? Sometimes people need to consider using some supplements to help with their stool consistency. And then we also look at your defecation technique, or the way that you poo. So we've sort of talked about the position to poo in, some of the breathing techniques to poo in. A big one that some people are talking about now is scrolling on your phone on the toilet, because lots of people take their phone into the toilet and might sit on the toilet for actually longer than they need to.
And apply pressure for longer than you need to?
Yeah, exactly right. So when you're kind of sitting on the toilet, your rectum is lower and gravity dependent, so there's pressure going there. So that prolonged sitting can kind of increase your risk of hemorrhoids. So a good tip if you're having hemorrhoids is to leave the phone outside of the bathroom.
Wow. And so you see women doing this? Because I hear that and I'm like, that just sounds like all my guy mates. I can't imagine women doing that, but yeah, I guess so.
Yeah, I mean, for some people, particularly maybe if they've got kids, going to the toilet to poo, it might be their haven. It might be their, 5 minutes of peace.
Do you see baby little hands under the crevice of the door? Mom, go away, please. Yeah. Let me doom scroll in peace.
Yeah, but leave the phone out of the bathroom if hemorrhoids are an issue.
Yeah. And so what else would you recommend for hemorrhoids? I guess going to a PT and talking about that.
Yeah. We'd want to make sure, we'd probably do a bowel diary with someone with hemorrhoids so we could check what their kind of pattern across a week or more is in terms of how often they're going and what the consistency of their poo is, what the urge to go to the bathroom is. And then we'd have a look at the muscles around the anus as well. So in addition to sort of the pelvic floor muscles that we've talked about, there are muscles wrapping around the anal sphincter. Some of them are that smooth muscle that we don't have control over, but some of them are striated muscle that we can control. So sometimes we need to look at someone's pooing technique and how their muscles are working with pooing. Common thing is called, not common, but something that we commonly see in the clinic is obstructed defecation or dysynergic defecation. The dysynergic means that the muscles aren't working how they should. So we talked about how you should be opening around the anal sphincter to poo, where there's that little bit of pressure coming down. But some people tighten around the anal sphincter when they're trying to poo, and that can make it really hard to fully empty your bowel. And makes you need to put more pressure around the anus.
And it's kind of that communication. If the smooth muscle is tense, then your body doesn't feel safe. Like, why do you not feel safe while defecating, right? So deep breaths, I guess, right position to kind of reduce the pressure, and then that prevents hemorrhoids from even forming and worsening.
Yeah, and it can be a bit of a cycle thing. Like perhaps you have one episode where you hadn't drunk enough water that day and you were feeling a bit constipated, so you did push and it was sore to push. So then your body remembers that and they're like, oh, it was sore to push out that poo. I don't want to push out that poo. So you avoid going, you put off going to the toilet, you tense to stop going, and then eventually you do need to go, your body's going to make you go, but you're still tensing while you're trying to go because your body remembers that it hurt.
It's almost like a child. Like I remember when I used to be a nanny, and the first time you have children, you've probably seen this, where they don't drink enough water and they have to sit on the toilet, and you can see that they are in excruciating pain, and you're like, sorry buddy, there's no other way out of this. And you can see the next time they go to the toilet, they're like on edge.
Yeah, they
like,
remember.
Is it going to happen again? And it's like we forget as adults that this happens psychosomatically. Like we're not actually fully aware of it. Like it happens under our consciousness.
And lots of adult bowel, bladder, pelvic floor problems can be traced back to childhood constipation. It's a big risk factor.
Wow. So if you were constipated as a child and you had trouble going to the bathroom as a child, that can extend outwards into your adulthood.
Yeah.
And so you see that correlate with hemorrhoids and issues with there.
I don't do a lot of pediatric continence stuff, but one of the physios in our clinic does. And I think it's such an important area. Like if you can get it right in childhood, it's going to set you up for a much smoother ride.
Wow, the psychosomatics of pooing.
Yeah.
So interesting. I didn't know that we were going to touch on that. That's fascinating.
And if you think about, the growing field of kind of the gut-brain connection, then, pooing is such an important part of our life, and often we get it so wrong.
Yeah. Okay. So thank you for all of that. Let's move on to more like prevention and maintenance, or maybe before we even go that, how can women in perimenopause support pelvic floor strength as estrogen declines? Because I know that those ligaments are held up in part by estrogen, and maybe that's one of the reasons why women experience poor pelvic health and maybe a more lax pelvic health as they move towards their perimenopause and menopausal years.
Yeah, great question. So perimenopause is one of the big times that we see changes in pelvic health. The sort of official word for it is genitourinary symptoms of menopause. So it's when women might start feeling more vaginal dryness or itchiness, or their bladder habits change. They're going more frequently or getting more urgency. And a lot of that is related to estrogen. Something that we as physios often recommend people look into, we can't prescribe it ourselves, is the use of vaginal estrogen. So it's not a systemic hormone, so it's not a patch or a gel or a tablet. It's a cream that you can use in the vagina, and it draws more blood supply to the vaginal walls and helps them kind of with their plumpness and their support of the pelvic organs. And it can help with the lubrication as well, because often we notice pH changes in our vaginal canal around perimenopause, and that's a big sort of estrogen-dependent thing. So getting back a bit more lubrication can sort of help with a lot of those symptoms. So that's something that physios don't do, but we recommend people can look into with their doctor. As far as what physios can do, we will often people come to us because they're starting to have pain with sex or they're having those bladder symptoms. So we'll look at how their pelvic floor is functioning. Often if it's related to pain, then perhaps they're starting to build a bit of tension into their pelvic floor. And you know how we kind of talked about with pooing, you might have one painful poo and then your body remembers that, and then you get tension and then it becomes more painful the next time. Same thing can happen with sex as well. So your vagina might be a bit dry, you have one episode of painful sex, and then your body's like, oh, the next time we're having sex I'm going to tense because I'm trying to protect it. So we can kind of help people get out of that cycle, I guess, and we can help people with their bladder symptoms as well. So if they're starting to notice more frequency or more urgency to use their bladder, we have lots of strategies that are not specific pelvic floor exercises, but other strategies to help with managing frequency and urgency. So we often talk about things like deep breathing to help kind of calm down the whole nervous system when you're getting that bladder urgency. Or we talk about using toe curls or calf stretches to help with bladder urgency, which sounds weird because why am I using my toes to help with my bladder? But there's a nerve that exits out the sacrum. One branch of it goes to the bladder. The other branch goes down the back of the legs to the toes. So we can kind of flood that nerve highway with messages from the toes or the legs. And it means that the kind of incorrect messages from the bladder don't get through to the brain quite so much.
That's fascinating. Nothing is in isolation.
No.
Wow. That's so fascinating. I would have never thought. And I kind of, that brings a little bit more credibility to kind of like acupuncture you might have on your foot, and like maybe foot massages and like calf movement and exercise.
And another thing that we're starting to do a lot more of now, it's becoming a lot more researched, is it's called transcutaneous tibial nerve stimulation. You might have heard of a TENS machine before. No, so it's a machine that has sticky electrodes that you can put onto your skin. Lots of people might use it for back pain. People use it in labour because it works on sort of the nerve pathways. But we are now using TENS machines on the tibial nerve to help with bladder problems. It's a form of neuromodulation. So it kind of resets how the nerves are working. Because often bladder problems, urgency or frequency, they're not a strictly bladder problem. They're not a pelvic floor problem. It's like a communication between the brain and the bladder problem. So we can kind of reset that.
Resetting and redirecting.
Yeah.
Okay. So those messages actually work properly, and it's actually representative of your urinary needs.
Yeah.
Is that something you see a lot in postmenopausal women?
Yeah, we do. Wow. Yeah. The kind of overarching term is called overactive bladder, but it's a bit of a misnomer because it's not always the bladder that's the issue.
Mm-hmm. Okay, thank you for that. So what are some practices that women can implement before dysfunction to support long-term pelvic floor health? Is this like exercises? Maybe you could talk about Kegels, because I know Kegels are very popular, but I think women actually understand what they are.
Yeah, so there's some research out there saying that just instructing a woman to do their Kegels, with a written brochure or whatever, around about half of them will end up doing the wrong kind of contraction. So I don't want to put anyone off doing some pelvic floor exercises, but I'll give a bit of a plug for pelvic floor physios. If you go and get your pelvic floor individually assessed, then you'll know what you need to work on. Mm-hmm. So you'll know if you need to work on the strengthening or the relaxation or the endurance. It can be a really empowering thing to find that out about your body.
Okay, so everyone should go to a PT at some point in their life.
I reckon.
Yeah. I think after this I'm gonna book in. I want to see what's going on.
It's just really interesting to know what's going on, and then you can kind of take control of that and progress it as needed. In terms of prevention, I guess one of the big ones that I encourage is to avoid those just in case wees. Well, I think Bluey calls them a tactical wee.
Bluey is in the TV show? Tactical wee? Oh my gosh.
Which is, a little bit different in kids than adults, but it's that, I'm just about to go out of the house and I don't know if I'll be able to get to the toilet for an hour. So I don't really have the urge to go, but I'm going to go just in case. Oh. And if we get into the habit of doing that, our bladder gets into the habit of doing that, and it doesn't get used to kind of stretching to its full volume. So I really encourage people to respond to the urge in their bladder rather than going just in case.
Okay, that's something I do. I'm like, I'm about to go. I'm just going to quickly go make myself do a wee. And I think maybe that's something that is ingrained in us as young children as well. We're about to hop in the car for an 8-hour trip. Go to the bathroom right now. I'm going to force you to go wee. So as parents, you don't recommend doing that. Don't teach that to your children.
I'm going to...
It's hard.
As a non-pediatric physio, I don't actually know what they recommend in kids, but for adults, certainly, if you, particularly, you might have only gone to the toilet an hour before you're hopping in the car. So your bladder hasn't filled that much unless you've downed 500 mils of water. So responding to the urge is probably the main message.
Don't preemptively pee. Always pee when you just want to.
Yeah.
Okay.
But don't tip too far into the other direction as well. Like, don't pee the minute that you get the urge to go.
Right. So if you have an overactive urine system, maybe hold off and see if you can fill up your bladder to its full capacity and then pee.
Yeah, so a normal bladder volume is about 250 to 400 mils. So except for your first wee in the morning, which is often a little bit bigger than that, but during the day, that's about how big your wee should be. And if you want to measure it, like, you can wee into a yogurt tub or something and then tip it into your kitchen jug just to know, what's normal for you. Because often we see people coming in and they're either doing lots of really small wees, like 100 mils, or sometimes it's the other end. They're doing, 700 or 800 mil wees. But we want somewhere sort of in the middle.
In between, to be balanced.
Yeah, and you should be able to go about 2 to 4 hours between wees as well. So over the course of the day, perhaps you're going 4 to 6 times. If you're going a lot more than that, then it can indicate either you're drinking too much water or too much liquid, which can be a thing, or your bladder's not expanding to its sort of full capacity before you're going.
Yeah, if your pee isn't a little bit yellow, that's what I say in my clinic. I think everyone's obsessed with this 8 cups of water every single day. My pee needs to be clear. I'm like, no, you're actually leaching minerals if your pee is absolutely clear. It does need to be a little bit yellow. It's healthy for it to be a little bit yellow.
Yeah, exactly.
Yeah,
right.
And so like consistently drinking too much water as well, I just don't think is very healthy. And so now we know it's just not good practice for pelvic floor.
And we
So
tend to focus more on your output of urine than your intake, because everyone's intake is going to be different. Like if you're a landscape gardener in Cairns working outside in the hot humidity for 8 hours a day, your intake needs are going to be very different to someone who's mostly sitting, working in an office, not doing much exercise. So the landscape gardener might need that 8 to 10 glasses, but the person sitting inside doing not much physical activity is going to need less.
So interesting, because I know a bunch of the women who listen to this have like the huge Stanleys and they just drink
so popular.
So much water. And I'm always thinking, I don't think that's natural. I don't think ancestrally that's what we did.
No.
We didn't have huge jars of water with us all the time, leaching minerals and putting huge amounts of pressure on our pelvic floor.
No. So the other thing is that we encourage people to kind of sip their drinks throughout the day rather than having a big dump all at once, because if our bladder stretches really quickly because our kidneys are trying to filter out all that water that you've just drunk, it can cause things like urinary urgency, like give you that really uncomfortable need to go.
That's so interesting. So those are a few tips for like pelvic floor health that's related to the urinary tract. Are there any other advice or like daily tips that you would recommend to women to maintain good pelvic floor tone and strength, and also relaxing it when it needs to relax?
Yeah, so thinking about relaxation, probably the best times to do that are when you're doing a wee and when you're doing a poo, because they're things that you've got to do every day. So if you can think about letting your pelvic floor relax at those times, then you're going to be focusing on relaxation at some point during the day. And then as far as other exercises through the day go, I think it's really important to know what you need to do as an individual rather than kind of generic advice, because some people do really need to focus on the relaxation. Some people need to work on the strengthening. I know, there's some advice out there, like every time you stop at a red light, do your pelvic floor exercises, which really gets my goat. Like concentrate on your driving while you're driving, and concentrate on your pelvic floor when you're doing your
So be connected, fully connected, and know what's actually right for you. And know if, my pelvic floor is a little bit lax, I need to focus on things that are going to strengthen it. If it's a little bit too over, hyper toned, maybe that's the word you can use for that. Maybe I need to focus on relaxing and maybe go to a PT and they can give you good advice on what to do.
Exactly right. So it can help for some people to have like little habit reminders of, when I log into my computer, I think about my pelvic floor, or when I get into the car before I'm actually driving, I pay 10 seconds of attention to my pelvic floor. But when you're actually at the red light, just think about the driving.
Okay. And before we close up, I just wanted to talk about like sexual pain and possibly even vulvodynia. Do you have any experience with vulvodynia, and like, can you talk to us about what that is, how it relates to the pelvic floor, and what the process is for women with vulvodynia?
Yeah, so if we break down the word vulvodynia, vulva means, we should do an anatomy lesson, because lots of people think that the vagina is just kind of the outside part of our genitals, but the vagina is actually the tube inside that goes up towards the cervix and the uterus. So the vulva refers to kind of the outsides of the genital. So that's the vulva, and then dynia means pain. So there's a couple of types of vulvodynia. There's provoked vulvodynia, which means there has to be some kind of stimulus to get the pain, like trying to insert a tampon, trying to have sex, or trying to have a pap smear, those sorts of things. And then some people have unprovoked vulvodynia, where they just have pain there even without a stimulus. And there's lots of different reasons why that can happen. Sometimes it's related to something such as endometriosis. Sometimes it's, after someone's had a sexual assault and the muscles have gone into that protect mode. There's kind of two parts to looking at vulvodynia, some part of it is looking at what's actually going on in the muscles, like are the muscles high tone in that protect mode, and then part of it's looking at what's going on with the central nervous system as well. So often we find that women have what's called hyperalgesia or allodynia, where their brain is responding to stimulus that might just be sex or a tampon, like it's a threat. So it might not be that the muscles or that area of the body is damaged, but the brain is seeing a threat there. So what we as physios have to do is work kind of jointly on the muscles and the brain to show the brain that having a penis inside or having a tampon inside is a safe thing to do.
Okay, so kind of like deep breathing, calming down the central nervous system, like that deep diaphragmatic breath to release and relax that pelvic floor,
right.
and that'll impact the vulva or the vaginal opening and the extension of that muscle. Yeah. Okay, beautiful. Is there anything else you wanted to touch on before we close up?
I think we've covered a lot.
We've covered so much. Yeah, and as I was talking about it, I was like, we can't really talk about one element of the pelvic floor without touching on everything else. It's so connected and dynamic.
And for such a small part of the body, it has such implications on our kind of overall function.
Yeah, on sexual pleasure, bowel movements, urinary continence, even like how stressed or relaxed we feel as well.
Yeah, exactly right. And something that, we haven't even really touched on that I know is important to you is our cycles. So we do find that sometimes people's bladder or bowel symptoms change with their cycle.
Before we close up, can we please talk about that? Because as we were talking about before, and like this is how you can use fertility awareness method, is that your cervix will kind of dance. So she'll move up when you're in your ovulatory phase, because I think it's so wonderful and interesting that those ligaments get pulled on when there's estrogen around, and that makes sense evolutionary, because we don't want to have the cervix laying low or midway between the vaginal canal, because what happens if we have a big penis entering and damaging that cervix? You know what I mean? So that makes sense. The body's like, okay, let's just make some room here. So you can go, okay, this is when I'm fertile and then this is when I'm not. And so I was thinking, okay, there must be a connection to a pelvic floor here. So could you talk to a little bit about that?
Yeah. So the change in the cervix is a big one. Change in our estrogen levels can often affect symptoms as well. So symptoms of prolapse or symptoms of urinary incontinence. And then bowel symptoms, lots of people notice change with their cycle as well. Yeah. So lots of people will kind of get constipated leading up to their period and then have a big release and everything kind of softens. Yep. And some people, until they connect the dots with their cycle, they feel so out of control. They're like, I don't know when I'm going to be constipated. I don't know when I'm going to, be having really soft poos. But when they can tie it into their cycle, the symptoms might not change, but their feeling about the symptoms can. Or sometimes we'll say, well, maybe you need to try changing what you're eating at that time, or changing, certain supplements, fiber things.
Yeah. If you're getting constipated in the luteal phase, I think that's so common because progesterone likes to switch our metabolism over, and we burn a little bit more calories, which means our metabolism should increase, but women are eating the same amount of food every single day when you should be increasing it by 30 to 40% in kind of that mid to late luteal. And so if you're not eating enough, then that bowel motility is going to move down. You're going to get constipated, which means you're going to have pain, which means your pelvic floor is going to be negatively impacted as well.
Yeah, exactly right. And some people notice their stress incontinence or their bladder leakage with running or coughing or whatever changes according to times of their cycle. Yeah. And, sometimes it does get to the point that it's still going to happen, but people can adapt their exercise around knowing when it's more likely to happen. So they might say, okay, I'm just not going to go for a high impact run at certain times of my cycle because I am likely to leak then.
Which, interestingly, you shouldn't be doing high impact when you're in your luteal phase anyway, because your metabolism shifts so much. Progesterone is a precursor for cortisol as well. And so that increases that incontinence and that constipation and impacts that whole system as well, which of course will impact the pelvic floor.
Yeah, so having just the knowledge or the understanding around that can be really powerful, because then people aren't like, oh, I'm crazy. Sometimes I leak, sometimes I don't. Yeah. it just gives them a bit more understanding.
Yeah. Oh, thanks so much for closing on that, because I was just like, I'm not sure how much she knows about cycle syncing. I don't want to throw you into the deep end.
I don't know if you've read the book Period Power.
Yeah.
So that's one that I often recommend to people who are trying to get a deeper understanding of what's going on.
Yeah, Vagina by Naomi Wolf is also really good to recommend, because she talks about pelvic floor and the connection of pain and the pelvic floor to sexual trauma as well. And she has a whole chapter on that, which I think is really wonderful as well. If anyone has had the experience.
I'll have to get it out from the library.
Yeah, you can borrow mine. Right, well, thank you so much for being on the podcast. I really appreciate your time. And
thanks for
if
having
anyone
me.
wanted to book in with you, where can they book in?
So we're at the Pelvic Studio, which is 24/33 Salamanca Place in Hobart.
Yeah, awesome. And do you guys do telehealth as well?
Yeah, we do. Often we do like to have people come for a face-to-face, at least for an initial, so that we can do a really thorough assessment. But if people are further away or not kind of, at that phase in their life that they can come in, we can certainly still cover a lot in telehealth.
Okay, great. Well, thank you so much again.
Pleasure.
Yay.
Yay.
Thank you so much.